cited authors in our field, and he's been a great mentor to many people. So thank you very much for sharing your knowledge, and let me pass it over to you, Dr. Bates.
Thanks so much, Yuri. And I'm told I have the ability to advance here.
Yep. If you see the bubble to your left on the screen, there's a number there and then an up and a down arrow. You should be able to advance your slides with that.
If you move your mouse to the far left.
Okay, let's see. Yeah. Yep. Okay. Great. Okay. Well, it's a pleasure to be here with you today. And Dr. Quintana asked me to talk about something that relates to quality improvement. And I elected to tell you about one evaluation that we're planning to do of a small, some technology that a small company in Israel has built that focuses on improving the quality and safety of medication ordering. This is an area that's been near to my and dear to my heart for a long time, and this little company's name is Signal. I'll be telling you about that, and we can then talk about whatever you'd like to talk about around quality and safety. Okay. So I'm going to start by giving you an overview of the Signal tool and sort of put this into broader context. Then I'll tell you about some results that we found in terms of evaluating this tool, and I'll put this into context with other studies, and then I'll wrap up. Drug-related problems are a significant patient safety issue. One study suggests that this could be as much as the fourth leading cause of mortality in the U.S. And 6 to 10% of hospitalizations are directly related to drug-related problems in some way. Clinical decision support alerts can be an effective way to reduce the rate of drug-related problems if they're patient-specific and highly tuned. But clinical decision support impact is reduced if too many clinically inappropriate alerts are presented, and that can lead to alert fatigue and introduce the risk of missing clinical alerts. And that's kind of where we are today. Alert override rates have been as high as 98% for many alert types, and clinicians just feel they're being bombarded. I mean, I feel this myself. In the past, many of the big implementations were done with internally developed electronic health records, but now vendor-developed electronic health records have essentially taken over the entire market. And the way things work in this area is you buy your electronic health record vendor from one, or your electronic health record from one vendor, and then you typically buy your medication-related decision support from a second vendor, and those come together, and that determines what alerts your physicians see. And the big problem is currently is that people are getting these very, very high rates of warnings, and many of them are just ignored. So here's some of the key messages from a review by Westerbeek et al. They suggested that barriers to effective clinical decision support were redundant and irrelevant alerts, specifically too many alerts. Often the alerts are too long, and they include excessive text. What physicians and other prescribers want is short messages that are to the point. Sometimes they're out of date, or there's actually a false basis of the alert. Often alerts are not contextualized. Very often they're not customized to individual patients, and we'll come back to that. That's really important. And it's been hard to customize alerts, and getting through them is time consuming, and often there are too many clicks involved. Properties of an effective clinical decision support application include that it should be sensitive and specific. There should be clearly identified criteria for severity ratings. So you can tell the things that are really important from the things that are not so important. It should be customizable. There should be a ready access to a summary of the clinical data about the patient. It ought to include management options, and it should ignore discontinued medications and non-interacting formulations. So often, for example, a drug is given as an eye drop, and if it's coming as an eye drop, interactions may not really be that important. So the Signal Pro platform was developed to be data-driven, and it also uses artificial intelligence and machine learning to come up with its logic, and it's intended to assist clinicians in managing drug-related problems. It includes a substantial amount of pharmacokinetic and pharmacogenetic information, and the company worked with Hansen and Horn from the University of Washington, who developed some of the best data about, in particular, about pharmacokinetics. It includes multi-drug insights, and there's patient-specific alerting. And inputs include medications, allergies, diagnoses, lab results, vital signs, smoking status, and the patient's genetic profile. It presents the most probable severe side effects and interactions, as well as more standard drug-drug and drug allergy interactions, and also duplicate therapies. It includes data from multiple curated drug databases. One of the tricky things is there are many sources of truth for example, areas like drug-drug interaction. But if you look at these databases, they often don't agree that well. It also uses algorithms to evaluate factors that enhance or mitigate drug-related problem risks, like things like dose, route, genetics, concurrent disease, and so on. It uses a graphical user interface instead of multiple paragraphs of tiny print, which people just don't end up reading. It presents alternatives based on patient diagnosis, and it's customizable by the user. And here's a slide which just shows some of the issues with drug-related problems. And there are issues both with the attributes of medications, but also with the patient's attributes. And some of the medication attributes include the long-term impacts of drugs, what other drugs are around that could be changing the metabolism of drugs. And then things about the patient that are important are things like their kidney function, their liver function, how old they are, and so on. And one of the big limitations of most of the vendor-developed systems has been that they don't take into account the patient's attributes. So, for example, until recently, Epic has not allowed customization of alerts based on the patient's attributes at all. And that is really a pretty big limitation, because the patient's attributes turn out to be extremely important in terms of what decision support you should supply. Now, here's just a mock-up of what is shown to the clinician. So the clinician will get a message saying that there's a potential drug-related problem. And here, the doctor is prescribing fluoxetine. Actually, sorry, the patient is taking fluoxetine. And that, there are issues with in terms of because they're taking propafenone too, that can increase the level of this between 50 to 400%. And there's also a moderate interaction over here between fluoxetine and aspirin. Okay, and a common therapeutic dilemma is you're giving a patient one SSRI, and you want to give you want to be able to think about what are the alternatives that might cause fewer problems. It's very hard to remember that kind of thing, but here you can very readily just take a look and say, well, maybe I won't prescribe fluoxetine. I could consider duloxetine, escitalopram. Here, there are no alerts if I use those things. If I were to use bupropion or paroxetine, which are other drugs that are used quite a bit, those do have some alerts. And it's a very rapid way of getting a sense of how many problems you're likely to have. So we did an evaluation of this software that was published in Drug Safety last year, and our goal was to basically get a sense for us, how big an effect it would have on the decision support that we provide. And we basically took up a population of patients, both an inpatient population and an outpatient population, and then looked to see, what alerts would be displayed if we use Signal and Epic versus what we are currently using, which is First Data Bank and Epic. So we, ran these populations of patients through the decision support, and then just looked to see what happened. And took a sample of the alerts fired by either system only or both, had those reviewed by 2 pharmacists who were blinded to the source of the alert to determine appropriateness. We calculated positive and negative predictive values, specificity, sensitivity, and the overall interruptive alert load. And the 2 populations included 657 inpatients, 2,731 outpatients. For some inpatients, the genetic data were available. That was analyzed also. Most institutions don't really include very much genetic-related decision support today. And we extracted 43 patient factors. You can see a list of many of these. And we took a random sample of up to 100 alerts from predefined categories, notably drug-drug interactions, drug disease, dosing alerts, duplicate warnings, geriatric warnings, pregnancy warnings, and renal dosing warnings. The appropriateness of each alert was blindly assessed by 2 pharmacists based on patient factors and using supporting data when necessary. It was a true positive if they agreed with the alert, false positive if they disagreed, true negative if they agreed not to alert, false negative if they disagreed not to alert. And those are just the formulas for sensitivity and specificity and positive predictive value. Here you can see the alert load. With Signal for 1,070 inpatients, there were 3,190 alerts. For Epic, there were 48,000 alerts. The sensitivity was much higher for Signal than for Epic, 91% versus 73%. And the specificity was very, very different. It was 99% for Signal and only 0.6% for Epic. In the outpatient setting, again, you can see this very big difference in the number of interruptive alerts. So for outpatients, 2,700 outpatients, there were 2,300 alerts. That still means you're getting, well, 1 alert for pretty much every patient. But here you can see there were 10 times that many. And the sensitivity here was 88.6%. Here it was 78%. Here the specificity was 99%. Here it was 0.3%. Here's some of the genetic data. So there's 657 patients with genetic information in both groups. And again, Epic generated a very large number of interruptive alerts. The sensitivity was higher with Signal. The specificity was dramatically higher. For outpatients, the results were similar. So overall, compared with Epic, the Signal platform triggered many fewer alerts in both the inpatient and the outpatient setting, and in the inpatient genetic cohorts. There was much higher specificity in the inpatient setting, in the outpatient setting, and the inpatient genetic setting. And at the same time, there was higher sensitivity in the inpatient and outpatient groups, but not in the inpatient genetic cohort. We did identify 16 adverse events that occurred in the inpatient setting. 11 of those, or 69%, could potentially have been prevented with the Signal platform. Overall, the Signal platform triggered 94% fewer alerts than Epic in the inpatient setting and 93% fewer in the outpatient setting, and had much higher sensitivity and specificity. And our feeling is that this application could substantially reduce alert fatigue, which is a big issue for us. We have a lot of physician burnout right now, and one of the things that people cite is alert fatigue. And at the same time, this could substantially improve medication safety. So, not surprisingly, our plan is to evaluate it next in a prospective study. Here's a study from Carly et al. Looking at the quality of decision support in computer order entry, and they did a systematic review, and what they found was massive variations in positive predicted value ranging from 8 to 83%. According to the object of the decision support, most of the results were pretty poor, between 20 and 40%. And the best results were observed if patients' characteristics like comorbidity or lab tests were taken into account. That makes clinical sense. And there was also major variation in sensitivity. Signal has already tried this out in a big HMO in Israel called Lumit. In almost everybody in Israel belongs to one of several of these big HMOs. There are essentially just 4, and that represents a really nice laboratory for testing things like this. What they found when they delivered decision support using Signal was that the likelihood of getting admitted to the hospital fell 5.6%, and the number of prescribed medications fell 7.8%. And this was compared with another U.S. solution, Micromedics, which is widely used here, and that had no impact at all. So the study that we're planning to do is to do a second study in which we will implement Signal within the Epic production system for a few selected inpatient and outpatient settings. And we'll, at the same time, do user research and usability studies to assess implementation requirements, make sure ease of use is okay, look at utility within the clinical workflow, and also clinician satisfaction. And we will, of course, measure how often the alerts fire, how often clinicians accept the alerts, and we'll look at changes made to medication orders. This does require some technical stuff. So the way that this would work is that this is what happens in Epic. There'll be a FHIR server. Medication orders will be written. That will come over to Signal, where we have the CDS services. Information will then be sent back to Epic, and information will be shown to the doctor. Their choices will then be relayed to Signal, which will look at what's been ordered, and then there'll be an HL7 push back to medication. The med list will be updated, and the order will be signed. So it's not trivial, doing this technically, but it's also, not extraordinarily difficult. And we think it's worth doing, as it will give us, hopefully a very substantial clinical benefit. Our hope is that implementation of this will result in transformational improvement regarding alert burden, which again is a very big problem for us, and at the same time improve sensitivity. And we haven't identified anything else analogous which would get us a similar level of improvement. So if this implementation goes well, the plan would be to try and spread it. Again, we're hoping that this will help with provider burnout and also with how decision support is perceived more broadly. Decision support has really kind of gotten a black eye lately because people have just been bombarded with suggestions, most of which are not things that they want to follow. And we're going to work with Signal, and we have opportunities to co-develop with them going forward, especially around genetics and artificial intelligence. So Katie is asking, what's the length of the new study and when will the results be available? And it's intended to be about 6 months long. And we're in the process of going through the preliminary work to actually get it turned on. We hope we'll be through that, in the next couple of months. But anytime you introduce a new application in an institution, it has to go through security review and all sorts of assessment. And we'll see. And we're not going to basically put this in and just flip the switch and turn it on for the whole hospital, because things could break, and medication use is such an important process. So, when will the results be available? It'll take a while after that. So I would say look for results probably a year from now, sort of thing.
Good. I think we have a question, Dr. Bates, and I'm going to let Yuri go ahead and ask that one.
Great.
Well, congratulations on a very rigorous study design. And one of the things that I was curious as, since it requires, it has AI, and one of the questions that's been brought up about AI is how do you validate the model, training the model and then validating it, assurance. I mean, I think those same questions about validating the recommendations are true even if you weren't using AI. But it tends to get a lot more headlines. In this particular project, what are the training issues that you'll need to do to try to train? Is it all being done with data from Israel, or will they also be doing some training with data that you have there? And how do you gain the confidence from your providers that the recommendations have been validated?
Yeah, so actually much of this is still rule-based, but increasingly we'll be using AI. We will be doing the training on data from here, because our expectation is that things might be significantly different, especially how the data are represented. As you probably know, the results of just taking one model and then plunking it down someplace else, using models like this have not been very good, and so I think it's really important to validate anything that leverages AI in the place that you're using it, and that's our plan here. That being said, most of what will be done for a bit probably will not involve any AI. But I do think that's the future, and that we'll be able to get to levels of performance that are higher than we've seen historically, by doing that.
And if there's time, just a follow up, when you do the study, is it sort of a randomized control trial? Are there certain clinics that will be using this new system versus the other as baseline, the current system?
Yeah, it will be. We'll do it as an RCT, and it's relatively easy to do that in a situation like this. And the results, I think, are much more compelling if you do it that way.
Okay. Terrific. Lance, are there other questions from the class?
Well, I think we're good at this point, but if we do have any other questions that come up, Dr. Bates, I hope you'd be open to us sending those off to you for follow-up, if that's okay with you.
Sure, absolutely, that'd be fine.
Okay, and
Sure.
thank you. Excellent presentation. This is something very near and dear to most of us are pharmacists, so this is right up our alley. So we're happy to see this work being done. So
well, thank you. I picked this because I thought that many of you would probably be able to relate to it.
Oh, definitely. So, Yuri, any closing remarks?
Yeah, thank you very much, Dr. Bates, for an outstanding presentation as always. And I think this module certainly shows rigorous research methodologies to improve healthcare delivery. And there's always tremendous things coming out of Dr. Bates's lab. So thank you again. And I hope the class enjoyed learning from all the different speakers today. So Lance, let me pass it over to you to close out the session. I know most of you have meetings at the top of the hour. Thank you, Dr. Bates, again.
Yeah.
Thank you. Take care.
Thanks again, Dr. Bates. All right, everybody, I did put in the chat the post-evaluation, but as always, we'll send that out. Yuri, thank you again for a great panel. We appreciate that. And again, just remember, we're off next month. Our next lecture will be in June. I believe it's the 24th, somewhere in there, but we'll get an email out about that. Thanks, everyone, for your help, and have a great weekend. Bye for now.